So I've been practicing neurology for over 3 decades, and so I was sort of hatched into a career at the same time that this whole HIV thing came. So all of this sort of came to me because of timing, but it's really been terrific. And thank you for having me. I've learned a lot today. I've been so impressed with all of the information I've gotten. But when I started giving these talks about HIV-related neurological diseases years ago, it was always about central nervous system disease. It was always talking about PML and central nervous system lymphoma and toxoplasmosis. But because of all these wonderful new things, I really don't talk about that anymore. So that's right, thank goodness, right? But we do have some chronic stuff, and so I was asked to talk about something very chronic, which is HIV neuropathy. My disclosure, I have nothing to disclose. Everyone knows everything about me. My life is an open book. But neuropathy with HIV is most commonly distal sensory, and it's very common. It's the majority of patients with this illness, and it's both a large and a small fiber process. But it also is a prominent loss of small unmyelinated, or what we call the C fibers, and that's very important because that is really the source of pain generation. The C fibers are really where people feel burning, tingling, numbness, all that miserable stuff that comes with this process. So it's very important for me to be sure when people come to see us that we are actually getting the diagnosis right. So if it's going to be an HIV-related neuropathy, it should be pretty chronic, and it should have had a very gradual onset over months to years, not days to weeks. We do want to see a length-dependent process, which means the further we go from the mothership, brain, the more symptomatic the patient is. So, brain, spinal cord, nerve roots, all the way down to those C fibers in the feet. We really want to see it really affecting all those little C fibers down in the feet or in the fingertips at times. HIV neuropathy is prominently sensory. It is very infrequent to have a significant motor component. What do I mean by a motor component? Motor component means somebody shows up with a wrist drop or a foot drop. That's really not common for this process. So sensory involvement precedes motor involvement by years. Occasionally you'll see somebody who's had this for 20 years, so now they're getting a foot drop. And it's always distal. Unfortunately, this is an axonal neuropathy. Neuropathies come in two flavors. They come in axonal and they come in demyelinating. When you kill the axon, you actually are harming the nerve itself. And in demyelinating neuropathy, you're just taking away the covering of the nerves. Our nerves work on a very quick electrical system, so they need to be insulated. The insulation is myelin, and viruses will sometimes take myelin down. Fortunately, myelin can be regenerated. So if something is a demyelinating neuropathy, we're a little bit better off. Unfortunately, with a chronic HIV-related neuropathy, we're often looking at an axonal pattern. So the small fibers give us what we call positive symptoms. When people come to neurology, we look for positive versus negative symptoms. So when we're talking about positive symptoms, we're talking about pain, numbness and tingling, paresthesias, or dysesthesia. People will say, I touch a cold floor, but it feels like it's burning hot. That's a dysesthetic process. But sometimes with HIV, the large fibers are also involved, and that gives you the negative symptoms: loss of balance, loss of coordination. People just can't feel where those feet are on the floor. So two different things there. Very atypical to have an acute onset. If somebody says this started 2 weeks ago, and that raises a red flag for me that there's another diagnostic entity. For doctors in neurology, we say bulbar involvement. To the patients, that would be double vision, slurred speech, difficulty swallowing, diplopia, dysarthria, dysphagia, brainstem problems. Not common in a basic HIV neuropathy. Neither is autonomic involvement. Because I practice here and the population skews older, I do see a lot of autonomic issues. I particularly see a lot of orthostatic hypotension, but to me, that's almost almost always a Parkinson's disease issue and not the HIV neuropathy issue. As we talked about earlier today, we have to start looking at these patients in their totality. They're living a long time, they're older, they're healthy, God bless them, but they start to get things like Parkinson's disease. So autonomic involvement and neuropathy doesn't really sing to me properly. And again, early or pure motor involvement without sensory, that wouldn't work right for the diagnosis. So we like to confirm diagnosis because we like to get it right. So we like to do electrodiagnostic testing, which is nerve conduction velocity plus EMG. And it's very important that those two tests come together because they give us different data that when we combine, we can get a clearer diagnostic answer. So it clarifies the diagnosis. It determines how chronic the problem is. It also tells me whether this is an axonal or the demyelinating type of neuropathy. And additionally, it could particularly change diagnosis and management because if the neuropathy turns out to be something demyelinating like CIDP, we've got different stuff to offer than if we've just got our straightforward axonal neuropathy of HIV. It's important to get both studies. I know people will sometimes come to the office and say, I don't want the nerve, I don't want the electrical shock part, or I don't want the needle part, and I have to sometimes do the negotiation. However, it makes a difference. In a nerve conduction velocity, you're sending down an electrical signal, and you're going to get two answers out of it. You're going to get an amplitude of a response at the bottom, and you're going to get a velocity of that response. So when we have reduced amplitudes, it's more likely to be an axonal neuropathy. But when we have reduced velocities, it's more likely to be demyelinating. So it helps, but then you take the electromyogram, you take your small acupuncture needle, thanks to Sony, you have a little microfiber electrode tip in there, and when it goes into the muscle and the patient voluntarily activates the muscle, we can transduce that energy into the computer system, and it will tell me this is not nerve disease. This is the muscle that's sick, or this is nerve disease, but it's very chronic. Also, it's nerve disease that's getting better. We see re-innervation happening. So particularly if someone's had something demyelinating or not an HIV neuropathy, the electromyogram also tells us where are they in the journey. So I encourage people to get electrodiagnostic testing because it adds value and validity, but it also needs to come with two components. Nerve conduction and EMG, they go together. They really should never be separated out. So other diagnostic testing, because we're so interested in those C fibers, those small unmyelinated fibers, we can do a skin punch biopsy now. It's very helpful. We can look at the intraepidermal density of those small fibers, and we can determine if there's actually a small fiber neuropathy. Why is that helpful? Because a nerve conduction can be normal in small fiber neuropathies, and therefore some patients are told, oh, your nerve conduction is normal, you don't have neuropathy. Well, not so quick. Why is this the issue? The issue is every nerve fiber has big nerves, medium nerves, and the small nerves. So when you hit it with an electrode to send a pulse down it, the larger, healthier nerve fibers are going to grab that and run with it. So the actual velocity comes up looking perfectly normal. So you're missing the function of the small fibers. So sometimes, even in a small fiber neuropathy, the conductions are normal, but when we do a punch biopsy in the office and send it out for an intraepidermal nerve density, we still will find a neuropathy diagnosis. Comes up actually not infrequently. Very rarely sural nerve biopsy. Sural nerve biopsy is really mostly for vasculitis, and it's very rarely necessary to biopsy a nerve. And it should be done under very controlled circumstances. You need to have the proper surgeon to take that biopsy piece, and you need to be ready to have a neuropathology lab at hand who is familiar with processing sural nerve tissue. So it's not something that should be done without a lot of discussion and planning. So the other big neuropathy that always comes up as an issue is whether people have chronic inflammatory demyelinating polyneuropathy known as CIDP. And that's a different neuropathy because it's treatable in most cases, but it's very symmetrical. and you get both distal and proximal weakness, and you get them in all four. And so when you see CIDP, it's going to look different. And this is something that needs a nerve conduction study because this is going to be demyelinating. We're going to see slowing of those velocities, but pretty good amplitudes. And we're going to see active denervation discharges on our electromyogram. So with the CIDP, it is antibody mediated. We have electrodiagnostic criteria for this diagnosis. We have to test at least 4 sensory and motor nerves, and they all need to be abnormal. So CIDP does have criteria. It's not just something we look at and say, oh, that looks like CIDP. We can test it. And as a confirmatory study, spinal fluid, cerebrospinal fluid will show you some elevated protein. Why is that protein elevated? Because remember in anatomy, when those nerve roots leave the cord, they are heavily invested in the dura. So if they are shedding protein, the myelin is just deteriorating. That myelin protein is going to come up in your spinal fluid sample. So for today's treatment, we do have gamma globulin, IVIG, and we do have steroids or plasma exchange. However, we're very fortunate. We've moved on. We now have subcutaneous IVIG, which makes life a lot more convenient for the patients, a lot more home-based, and it's a lot more popular, and it works just as well. So, excuse me. So then risk factors for neuropathy are always multifactorial. Certainly the virus itself can do some nasty things to the nerve, antiretroviral medications, of course, but you can get other opportunistic infections that are wreaking havoc in the nervous system too. Although nervous system tissue is slow to heal and is very fibrous and is very different than skeletal muscle, for example, it is still part of the living system. And so when other systems are off, the nervous system tissue will also reflect that. So we know that there's infection of the nerves even without clinical symptoms, which means pretty much when I do a good exam, hopefully I mostly do, often I will see signs and symptoms of neuropathy that patients are not even there for. They're there for something else, but I can see it. I've got distal loss of reflexes. I've got wasting of intrinsic muscles distally in the feet. I've got some sensory deficit and in a stocking distribution. Also, there's neuropathy there. And of course, in postmortem tissue, it's almost universally found. But we know that there are pro-inflammation issues like cytokines that are actually hurting our sensory nerves where they are born in the dorsal root ganglion. So the pathology is multifactorial, but pretty well described at this point. Some people think the antiretrovirals originally were causing some mitochondrial dysfunction, which led to a lot of interest in coenzyme Q10. But we certainly know that HIV envelope protein GP120 mediates Schwann cell toxicity. To come back to neurology again, Schwann cells do make our myelin sheath. They're very important. If we don't have healthy active Schwann cell populations, we're going to demyelinate and we're going to have unhappiness in those nerves. There's also probably neurotoxins that are released by very activated macrophages. So inflammation is still an issue. Thank you for telling us that we're not using these mostly nucleoside reverse transcriptase inhibitors anymore. These so-called D drugs, DDC, DDI, D4T, sort of a problematic issue in our practice for patients all the time. I won't miss them, although I do believe there's still some element of neuropathy induced by some of the other agents that we're still using. So when it's antiretroviral therapy-induced neuropathy, the symptoms are kind of similar, but it's more acute onset. Most patients will notice it within 6 months of starting the therapies, and very distinct from most HIV neuropathies. You will see involvement of fingers early in the game. That's generally doesn't go with most neuropathies. Most neuropathies really are feet-focused, but medication neuropathies, and we see this a lot with chemotherapy-induced neuropathy, fingertips, very early on in the deal. And again, these are neuropathies that, of course, if you remove the agent, we will start to see improvement. So We've talked a lot this morning with a lot of other great speakers here about comorbidities of aging. At least here where I work at Palm Springs, a lot of the HIV population is definitely aging. And so neuropathy is very sometimes seen and has nothing to do with HIV. We still have to look for the usual factors. In the United States, if they are of a certain age and they have neuropathy, it's always diabetes, alcohol, drugs, and B12, 1 through 4. And so we have to do our business looking for all those alternatives. Also, neuropathy with HIV issues is always a symmetrical and a bilateral event. If something is unilateral, it is probably not in my department. I've seen lots of interesting things sent as neuropathy because everything that tingles comes to the office. But I have seen gout, I have seen radiculopathy from a lumbar nerve root irritation, I've seen peripheral edema, I've actually been seeing cellulitis. So it's good to have some medical background sometimes. So occasionally there is an acute neuropathy with HIV that's generally associated with seroconversion. With seroconversion, it's usually the Bell's palsy, it's usually the facial nerve, facial mononeuritis. And sometimes it will even look like Guillain-Barré or acute inflammatory demyelinating polyneuropathy. So emergency room patients that have new onset Bell's or patients in the hospital that come in with a Guillain-Barré syndrome and AIDP, we always do an HIV screen on that. Very rarely, we see mononeuritis multiplex. Just to refresh, mononeuritis multiplex means you've got a carpal tunnel on this hand, but you've got a peroneal nerve palsy on this leg. So you have multiple individual nerves that are not functional. And that's more common with CMV. It's more common with hepatitis C, but it's sometimes seen as a marker of vasculitis. Other things that we sometimes come across are zoster, causing radiculitis, that's shingles, common, and occasionally an autonomic neuropathy, but again, with HIV, autonomic neuropathy, very rare. We do know for people who have the diffuse infiltrative lymphocytosis syndrome, they can present with polyradiculopathies, radiculopathy meaning nerve roots, rad for the Latin for root. And we also know that with CMV, we get the cauda equina syndrome, very early on bladder involvement. If we look at an MRI, that cauda equina, the horse, those nerve roots at the base are going to be thick, they're going to be clumped, they're going to be enlarged, and they may even be contrast enhancing. So you see a lot of bilateral leg weakness, you see early urinary retention, it's often CMV, and that can be an HIV-related issue. Lastly, very rarely, and I can claim to have heard of one, we can see HIV come to us looking as a motor neuron process. Most commonly for motor neuron disease, people think of ALS. We're trying to move away from the moniker of Lou Gehrig's disease. But this shows up with the usual fasciculations, but hyperreflexia, too much reflex. So there's a combination of an upper motor neuron process and a lower motor neuron process. This seems to go away very, very beautifully once people get treatment. But I will tell you, I see a lot of fasciculation, and most of the fasciculation I see is benign, and it is because my population tends to go to the gym a lot, like a lot. And so it is mostly fatigability of the muscle. So the benign fasciculations are commonly seen in this population, but they should not be accompanied by hyperreflexia. As long as there's just fasciculation, if the reflexes are normal active or hypoactive, I have a sigh of relief. So treatment, we're going to take away anything that's neurotoxic if feasible. We're going to correct those comorbidities, and thank you, Dr. Del Rosario, for bringing attention to metabolic syndrome, which is a big risk factor for neuropathy. And then, of course, we can use neuropathic pain medication if necessary. We don't have cures at this time, but we can make people more comfortable. So the initial neuropathic medications for pain were the tricyclics, and the data is really best for amitriptyline and nortriptyline. The doses, sometimes these are so idiosyncratic. I've got people who take 10 milligrams of amitriptyline and they feel perfect, and then I have other people who need 150 and then they're doing okay. As the population has aged with HIV, we're a little less enthused about tricyclics because of the anticholinergic side effects. However, to be fair, these drugs work and they're very, very affordable. And they have once-a-day dosing. So they're not the worst choices. We now like to use the serotonin norepinephrine reuptake inhibitors. Duloxetine is, of course, the most widely prescribed and studied for neuropathic pain. It's dosed between 30 and 60 milligrams per day, although occasionally with bad enough neuropathy, you can do 90. I have never seen benefit over 120. There's rarely a few folk out there on that super high dose, but I wouldn't start there. Our rule with neuropathic pain medications is always to start slow. You can always increase, but you can't take it away easily. So go slowly. Lots of topical gels and compounded anesthetic agents out there. I learned this long ago from my colleagues in pain management. These gels are very cumbersome to use, but they work. You get nice anesthesia. People can apply them to the affected area, which is generally soles of the feet and the toe box. And after a few days, they actually will start to kick in. Please tell your folks to wear gloves so we don't get anesthetic hands. And there's a variety of choices of how you want to compound it. You can pick your poison, so to speak. Problem is they're compounded, so they're not covered, so they can be a little pricey, but there's some really nice mail order pharmacies now that will do this for us. And you get the advantage of no systemic absorption, so you don't have to worry about drug-drug interactions or side effects. So there we go. And then the big the go-to drug, gabapentinoids. A friend of mine, a colleague of mine said to me, "We're talking about neuropathic pain and HIV." I said, "Yes." He said, "Say gabapentin and get off the stage." So this is definitely the most widely prescribed agent. And I was involved in a clinical trial with this, looking at low dose versus high dose. The high doses are more effective, but of course they may be less tolerated. And the dose range is idiosyncratic, again, and variable. You can get people comfortable on 300 milligrams a day sometimes, but often you're up at the 3,600 mark. Where does the 3,600 mark come from? Gabapentin was initially developed as an anti-epileptic drug. So in epilepsy patients, we do need to move towards 3,600 for seizure control. However, there is a wide range of tolerability. And in fact, I have had people at 4,800 milligrams per day in divided doses, and I have one person who holds the record at 8,000 a day and looks fine. I call him a gabapentin sinkhole. So, yeah, it's crazy, right? Wide awake, crazy. Generally, for those of us who do a lot of gabapentin for many different diseases, usually looking at success at about 1,800 milligrams per day. That's kind of your sweet spot. When you're under 1,800 milligrams a day, at least you know you have a place to move to. But we find in general that if you're going over doses of 1,800 milligrams per day, you tend to start to see more side effect than benefit. And I will say this, when they get into high doses, then they're in my office because of other things. They have tremor, they have ataxia, they have cognitive clouding, they have daytime sedation. So be careful to go slow, dose escalate as needed, and also you must dose adjust for renal impairment. Get a lot of patients wind up in the hospital dehydrated, they have acute kidney injury, they are low GFRs, high creatinines, and I get myoclonic jerks. And the first offending agent there is the gabapentin has to go away. So we do have a prodrug, we have pregabalin, but it's controlled and it's more expensive. It also needs dose adjustment for renal impairment, so there's no great advantage there. It's just a gabapentinoid. They're very structurally similar. They work on the GABA inhibitor neurotransmitters in the brain and the cord. They reduce the release of excitatory neurotransmitters because GABA is an inhibitory neurotransmitter. And the supposed advantage using prodrugs is you may get a better serum level faster. But you get a lot of weight gain on pregabalin, and so that's sometimes not the most popular. And it's a scheduled issue, so you have prescribing issues. It's a bit of a hassle. I think we do just as well going back to gabapentin. And lastly, there are a lot of alternatives out there, and I firmly believe in them if they're working. I don't mind. People want to do acupuncture or exercise. I will tell you this, though, there's no universal consensus that any of these listed modalities works. The data is conflicting because the studies are small and they're not well constructed in some cases. And I will also say that unfortunately, we have not seen great stuff with stem cells or nerve growth factor for neuropathy at this point. One last thing, can't go back there, so I'll leave it. One last thing I will say, we have really exciting stuff happening in neuromuscular disease, particularly for diseases like myasthenia gravis, and it's sort of monoclonal antibody mediated. I think that's coming for neuropathies. So we are almost there. We are close to having some good new stuff, and I would encourage you to tell your patients to hang in there on this topic. And lastly, I do want to say deep gratitude is owed to literally the thousands of patients I have seen over the years with these conditions. They've really taught me a lot about how to cope with some very tough stuff in life with a lot of grace and dignity. And I thank them.